know who we are.
Do you have any plans to expand your service to other parts of the country?
No, that was a,
I bet you get that question a lot.
yeah, we're gonna do that a long time ago, but I just decided rather than spread it all out to keep it focused, and I think we've kept it focused, and we could just control everything under this roof and deliver the best imaginable care. Yes, sir.
Technology changes very quickly nowadays versus 5-6 years ago.
Sure.
How do you keep up with the latest technology on equipment versus the, I'll call it the Moffats, the Mayos, those places?
Yeah, well, we've also been fortunate from the standpoint of having some very wealthy donors, who have contributed to our technologies. And so we're always looking for the very best technologies and implementing them whenever we possibly can. But we're also unique from the standpoint of how we've developed our radiation delivery system to be very special and precise. And, the DART refers to dynamic, and it's a dynamic treatment so that we know that the targets in the prostate region are moving all the time. And so if we just develop a static plan of a patient and say, this is what we're going to treat, press the button, it's going to be treated, the whole area is going to be treated to our precise dose. Well, that's what most places do. But what happens is the areas, the targets that we're planning on hitting aren't there anymore. They're moving. So we have to be dynamically adjusting our targets, our microbeams to those targets in real time. So that's what makes us very interesting. And, others have tried that with other modalities like protons, but there's some shortcomings with protons as well. I have a lot of experience actually with protons and other tools to try to track the gland dynamics. We have many. Anyone else? Yes, sir.
For, again, reoccurring, which is me,
Okay.
do you use anything like bioprotect or some other type of modalities to protect the rectum from salvage radiation?
Yeah, so even with salvage treatment, we do use a hydrogel to space the rectum from the prostate bed, because you still have a prostate bed, okay? And, if we were to measure your prostate bed, I don't know how big it would be, but it's typically between 2.5 to 5 cubic centimeters. Normal prostate is 20 to 25. So there's still between a fifth and a quarter of tissue behind. And if it's spaced so that we can use the hydrogel to space the rectum from that. Now, sometimes the cancer actually invades the rectal wall, and then it's not wise to do it. And we make that decision with each and every person. And sometimes the patient's actually on treatment, and we identify, because we do real-time imaging too, so we see the treatment that patient's having per day, identifying, are we doing what we wanted to do, in real time. Sometimes even a patient will hear, you're going to get your hydrogel put in. Have a patient here, he didn't know it, but yesterday it was done. And it's not the most pleasant procedure, unfortunately, but it's also not worth bringing a person to, OR, putting them under anesthesia and all the complications with anesthesia. So it's kind of quick and fast. But anyhow, so we do it right here. Okay.
And have you started using the new seeds yet? The cesium?
We have, and we'll be doing some comparative analyses with the different seeds. So we've used a lot of seeds, and we use them all. I mean, we're kind of the epicenter for brachytherapy. So I've used everything you could possibly use, from something called high dose rate iridium 192 for prostate treatment. I don't recommend that. I did it a lot in the past. I've used iodine. I've used palladium 103. In fact, I characterized palladium 103, and we're looking at cesium 131. It's a very interesting isotope. Has potentially some advantages even over palladium, but we'll eventually do that analysis. But right now it looks pretty good. the patients who were currently treating with the recurrences who've had previous radiation, we're thinking there could be a potential advantage to the cesium at this point in time. But the data that we published is primarily on palladium. So, and we're also looking to take our procedures outside of the hospital. I always thought it was a little bit too much to have a patient admitted to the hospital. You know, the hospital then dominates the picture cost-wise and duration, and you know, it becomes a really costly endeavor at the hospital. So right now we're involved with a surgical suite on Tuttle Road, and to do the procedures right there. It'll just be faster, quicker for the patient, and less expensive for the patient. So
Sorry, what procedures for seeds?
for brachytherapy or biopsies. Okay. So in your case, you've had your prostate removed, so it would just be a matter of coming in here, having us define, you know, where exactly the cancer is in the bed, and kind of.
But what scanning for PSMA PET scans? Do you use gallium, or do you prefer the F-18?
I don't. There was a time I had a distinct preference for the gallium, because we worked with the University of Michigan for a while and really liked their PSMA PET scans. And when it first became more of a community treatment, you know, or diagnostic tool, we again saw the advantage of gallium.
Dr. Dattoli.
But that has kind of moved,
Dattoli.
and you know, now I would say it's clarified. You know, is probably just as good as gallium. A lot of times we kind of make the decision, or let me say the insurance companies make the decision for the patient, but fortunately there's no great difference between the two now. You know, the radiologists have gotten more
Like tornadoes?
familiar with the
possible
test.
tornadoes,
Because
flooding.
for a long time, they weren't. And so, and I still have to review every single PSMA PET scan that's done, because we'll commonly find things that others didn't. But it's because we were involved with PSMA testing from the get-go. We were doing, interestingly, we were involved here with a nanoparticle test, which initially was called Commudex, and we worked with Harvard and University of California, San Francisco, and this university in the Netherlands with nanoparticles. There was nothing like that for diagnostic imaging for prostate cancer. It showed sometimes less than a millimeter of disease. So we actually started talking about, you know, microscopic disease, and there's some posters up there. You could read about it. It was called Commudex. Then we called it USPIO. It was an ultra small superparamagnetic ferrous oxide nanoparticle. Very interesting. And it really enlightened us between 2008 and 2018, just how common it was for prostate cancer to afflict lymph nodes. And in fact, until I started really focusing on lymph node treatment, we weren't hitting the 90+ percentiles of prostate cancer. You know, and now we have a really good understanding of lymph nodes, and you know, I've seen it all. I've seen, you know, the teeniest, tiniest Gleason 6 tumors who got nanoparticles, and guess what? Microscopically, it was in nearby lymph nodes. You know, so it's really that kind of disease. You probably, you may not know, but prostate cancer shares a lot of similarities to breast cancer. Breast cancer is fed by estrogen, the female hormone. Prostate cancer is fed by testosterone, the male hormone. You know, each are associated with something we call field cancerization. What that means is that every part of the gland is affected and will become cancerous in the prostate. That's one of the reasons why I got away from doing focal therapies like HIFU and cryosurgery, because
your calendar for March 29th.
you're just treating one area. That's pretty much what you want to do to lessen side effects. You know, and the PSA typically goes down. You know, let's say with 5, it goes to 2 or 2.5 for a year, and it starts rising again. You do all this imaging, and you find it's in another part of the plant. We call that field cancerization. What's afflicting one area is going to happen to another area. Breast cancer is exactly the same. They both go by this field cancerization process. And of course, for those who may know loved ones who've had breast cancer, they commonly afflict lymph nodes under the armpit. Prostate cancer almost always goes to lymph nodes in the pelvis. And there's a lot more lymph nodes in the pelvis than there are in the armpit. So
So
Yes, sir.
for salvage radiation, when you radiate, you hit all the lymph nodes, I'm guessing as well, because I think Dr. Myers, you worked
We
in the
did.
past.
Yeah, he and I were involved in a lot of these trials,
on
I tell you,
Thursday.
with the nanoparticles, USPIO. The only place unfortunately that's still doing that is the Netherlands.
Is it worthwhile jumping on a plane and going to the Netherlands to get
It's
it
a
done?
great, it's a great study, you know, it's the best. I don't know of anything like it. But PSMA is okay, but the PSMA, we're coming to find it only shows larger disease, you know, more macroscopic, 10 to the 6 or greater, billion cells or more.
No, I had a PSA of 4, it seemed low. I had that, what's that number?
9,
My other, what's the most important number? Which is I was at 9,
yeah, Gleason score.
the Gleason score.
Yeah, and this is the problem with high-grade tumors. And, you know, we appreciate it greatly. I've treated men who I've done biopsies of PSAs of 0.4, 0.5, but loaded with high-grade tumors. What happens is the closer the prostate is to the normal prostate cell, it'll make more PSA. But what happens is as you digress, so as you go from a early stage prostate cancer, let's say Gleason 6, well, that looks a lot like normal prostate cells. Normal prostate cells make PSA. And when you have BPH, benign prostatic hypertrophy, you have more normal prostate cells making PSA. That's why men could have a PSA which is not cancerous, 4 or 5. I've seen them in 20. But the fact of the matter is as the cancer mutates, it looks less like the parent prostate cell. So as you go from 6 to 7, 8 to 9 to 10, it's not obliged to make PSA at all. We commonly see Gleason 9, 10 tumors with very low PSAs. And that's what gets our attention too in the salvage situation, because we know that it doesn't, you know, a lot of times urologists aren't even aware of this concept about, you know, PSAs being fairly low with higher Gleason scores, and they still follow the general guidelines in a patient post-prostatectomy, where PSA is ideally undetectable. But when it starts going up, you know, from 0.01 to 0.02, with a Gleason 9, that could be very meaningful. It could speak for more volume of disease, you know. So these are some of the issues, but
How does Decipher factor into a lot of your
Yeah.
treatment?
we did a lot of Decipher, we did Polaris, we did 4K score, and you know, I do a lot of biopsies, and what happened was, you know, the scores would be low, showing low risk disease, and then I would end up doing scans and studies, and the patient could actually have metastatic disease spread. So I just stopped doing them. One of the tests that I've always felt to be the most important is something called PAP, prostatic acid phosphatase, and I published on that extensively. And I would say that's much more important than a Decipher, Polaris, 4K score, all of those. And I just got soured by doing so many biopsies. And you know, the immediate post-biopsy review with Decipher and Polaris showed low risk, you know, 5% chance of ever developing metastases. And then I would do scans, you know, even bone scans, and pick up, you know, metastatic deposits in different parts of the body. So I'm not so keen on those tests, frankly. Yes.
From the live stream, John asks, if testosterone feeds prostate cancer, does taking testosterone supplements after brachytherapy increase the chance of prostate cancer recurrence?
Yeah, so it depends on the type of supplement. If it's truly a supplement, the answer is probably not. There are some concerning ones at GNC, maybe called X-Test and things like that. Those are a little more concerning. Certainly testosterone, you know, we don't encourage. Interestingly, right now, there's the oncologists feel that testosterone is definitely a promoter of prostate cancer, and they're not recommending testosterone replacement in men. So the endocrinology societies who commandeer all of hormones are saying no. The oncologists are saying no, but the urologists are saying yes, and they're giving, you know, monthly injections. I'm not sure if the person asking is talking about supplemental by injection or pill or salve, or taking it by an oral supplement such as, let's say, Xgest. And we have some that we actually sell here, male support.
That's what he's taking. is
Okay, yeah,
yours.
those are safe. So, yeah, those are safe, and everything we do is always going to be oncologically safe, obviously. You know, if we're promoting it, this is what we do. We're a prostate cancer center. We also treat breast, and I think we're pretty good at that too. But I'm focused on prostate.
Do urologists in general, do they ever send you patients? I mean, do they know about you?
They do. You have to understand there's a lot of competition. There's just tremendous competition in the field, and if they're in another state, where they're not being competed by, and the patient's already told them he's leaving the state, then they'll say, oh yeah, go to the Dattoli Cancer Center. But if in your backyard, it's not that way at all. It's pretty almost evil, about it all. So it just depends. But yeah, we have plenty of urologists, do refer to us. You had mentioned University of Virginia. I have a doctor there, a friend, became a friend, and I have many around the country who do refer to us. But once they've given up on patients to get surgery, then they're more apt to say, okay, get your radiation in Florida. So, yes.
Dr. D, I really like that you are, that you prescribe or suggest that Jeff takes certain supplements. I think that's really good. So you're more holistically minded, right?
Sure.
And I think that's a great way to go. I have a friend who just suggested to me that maybe Jeff could be on CMOS. Do you have any thoughts about that?
I don't. I haven't looked into that particular one. But there's a lot of supplements out there. We now know that cancers, and especially prostate, are promoted by fats, saturated fats, which is primarily, beef and pork. And, a lot of times people think, oh, not pork, but it's, they say it's the white meat. No, it's really bad. It's a bad saturated fat for cancers, and especially prostate cancer. But, we kind of like to get our patients into a healthier mode, dietary wise, and, if you look around the world, there's these, now there are 8 blue zones where people live into their hundreds, and they all seem to abide by a Mediterranean diet, which is fruits and vegetables. And when they do get proteins by meat, it's typically by fish or poultry. And that seems to be very helpful. And of course, they're very active, and all the blue zones are in warm countries as well. You always see palm trees, and so Florida's got that going for it too,
And olive oil. Don't forget the olive oil.
And the olive oil.
Drink it.
Yeah, so probably the most nutritious food of all is going to be avocados, and everything. It's going to be extra virgin olive oil, and because cancers are promoted by inflammation, and what happens is those bad foods, saturated fats, processed foods, they're going to make you inflamed. Okay, they're going to promote all kinds of diseases. So it appears that by taking select supplements, eating healthy reduces the inflammation burden. And there's some supplements like turmeric. Okay, it has anti-inflammatory properties. Resveratrol, which is in red wine, okay, has anti-inflammatory properties. But I tell people, you have to be a wino to get that, benefit from the anti-inflammatories. But some people say, okay, But anyhow, yeah. So, but there are many, and certainly, again, we're learning more and more and more about how our immune systems are so important with cancer and prostate cancer, and that's why you're reading more and more about using immunotherapies. As I started this talk up, I talked about the company that sponsored your food this morning, and that's Dendreon company makes Provenge, and that's a tailored immune therapy, and it's very interesting. But a lot of other therapies can knock down the immune system, and it's the reason why I'm also not sold on the triplet therapy for prostate cancer, which does use a chemotherapy agent, docetaxel. I'm not impressed by the data compared to other second-line hormonal therapies, but you know, as we go into this path of boosting the immune system, I'm less apt to recommend something that drops it, like chemotherapy. And as I also started talking about good radiation, you know, radiation definitely upregulates the immune system. Hormones upregulate the immune system, and when you give them simultaneously, there's a really big peak, a big immune response. But other vitamins, like, first of all, D3 was the first vitamin that we learned a while ago had some relationship with prostate cancer. And when I first learned that, there were some studies out of the National Cancer Institute. I had thousands and thousands of men coming here for follow-up. And I started doing routinely on every single guy vitamin D3, the 125 deoxyribose, and deoxy-OH, I'm sorry. Anyhow, we came to find that almost every man was deficient in vitamin D3. Not everyone, but almost everyone. And then when we tracked the patient, it seemed like they also had almost a resistance to vitamin D3. So we had to get up to 5,000, you know, at least in a day to get our men to have normal D3 levels, you know, vitamin D3. So I do recommend vitamin D3. I do recommend other things that stimulate the immune system, like zinc, vitamin C. There's another one called quercetin, and I do recommend those. And we don't, maybe soon we'll have quercetin in our, you know, supplements that we offer here. But I think the immune system is really important now. And, you know, you're going to be hearing more and more about really, really bad cancers, you know, pancreatic cancers and other GI malignancies, you know, people taking immune therapies and they're just being just fine. You know, there was a recent, and the other thing is, you know, mutations. So we're coming to find that certain cancers, and prostate cancer has certain mutations which could benefit the patient by targeting those mutations. And we do that almost in every patient. It's called a genomic profile. And it's actually a molecular profile. So it's looking at a patient from the standpoint of, do you have a familial type of cancer that's, you know, ingrained in your DNA, which could be important to your children and siblings, or is it your cancer that has a specific mutation that we may need to target? But that's come a long way too. Yes.
Do you do the genomic testing like Garden 360 or Foundation or Promise?
Yeah, I've used them all. I do like Foundation One a lot. We like Invitae as well. And there are others out there now. They've gotten really good. So it used to be that to identify your mutations, you know, be it's a genetic one where you have a familial trait, somatic, meaning your cancer itself. We used to find that the best of all was to actually look at the pathology. So, for example, prostatectomy specimens, subject those, or biopsy specimens, subject those to a test. Then it was Foundation One by far was the best to do that. They've gotten really good though, what we call, from blood draws. And we call it liquid biopsy. So with blood draws, I think right now they're about as good as you know, looking at the actual tissue, you know, and so that's where Guardian 360 and, you know, there's a whole sundry of them now, you know, that are out there, which are very interesting. But we do them, and sometimes we find mutations, we don't treat them, but it's a good thing to know for the patient to know that he has that mutation. If the cancer ever comes back, despite all of our efforts, you know, it's not an end game. You know, we still have something left.
So hypothetically, if we were to get treated here, you would prescribe that Guardian 360 test?
Well, Janine, we're more commonly doing Invitae now and Foundation One.
Yeah, Invitae and Neobear.
Yeah. Is there anyone else?
I'm taking an awful lot of pills.
Okay, so
Is everybody else?
yeah. So here's what it is. First of all, I'm not a hormone bug, nor is Dr. Soni, and we don't like to pile on a duration of hormones. Okay, meaning many places are going to recommend, you know, 2 years, 3 years of hormones continuously. And I do have a problem with that because while certain cancer endpoints are thought to be better, there's other things that occur, like hormones accelerating cardiovascular disease, strokes, dementia, things like that. So our position is, if we're going to use hormones, we're going to do it for the shortest amount of time that probably anyone has recommended. But when we do, we're going to compact it. Okay, we're going to give a lot. And the reason that is because most of the hormone side effects come from the injection, which are known by different names: Lupron, Trelstar, Eligard, and Zoladex. You get the injection, or Orgovix, I should say, which is a pill form of those, and you buy into the side effects of hormones. If you give more agents, you really don't get many more side effects. In fact, some of the other agents that you're taking are to negate some of the side effects of hormones. So, for example, we like to use non-hormones like metformin, which has a pretty good role in being anti-malignant, anti-cancer. It has properties which can not only reduce diabetes, but anti-cancer properties. Celebrex, which is an arthritic med, it follows a COX-2 inhibition pattern, and it actually has prostate cancer effects. Statins actually do have prostate cancer benefits. So a lot of that is what we pile on. Some of the other things we do patches, okay, transdermal patches, because for a couple of reasons. Number one, the injectable gives you hot flashes, but the patches can actually reduce hot flashes, but also the patch has a pass through the liver, so it doesn't engage any clotting mechanisms in the liver, but also has a better impact on bone. And so we like that in patients who have bone disease, and we do treat a lot of people who do have bone spread, and we do really well with them with a lot of different agents. But one of those is transdermal patch, estradiol patch, and it directly impacts the bone, and we feel that's important, and it lessens side effects with hot flashes. So it's kind of a win-win. And there are just other things we use, for example, a drug called cabergoline or cabergoline. And while prostate cancer is fed by testosterone and DHT, prolactin, which comes from the brain, pituitary gland of the brain, has a really powerful stimulus on prostate cancer, 10 to 20 times. So cabergoline doesn't have really any side effects, but it has great anti-cancer benefits. So that's what we do. And in select people, some people I don't use any hormones at all. It just depends on the case, and we really try to tailor, our treatments to the patient. So because you may be in our waiting room talking to people who are on 20 agents, and others are not on any at all. It just depends.
Do you think artificial intelligence is gonna help you here?
Probably, sure, most definitely. Yeah, I mean, all you have to do is go to ChatGPT and ask an oncology question. It's pretty impressive what they come back with, But yeah, they can just figure it all out.
Is Watson still, are they a leader in artificial intelligence for medicine? Or Watson could be,
Yeah, I don't know about that.
Yeah.
I'm sorry. Are there any other questions?
I just got a statement. I was gonna say, I'm from Michigan,
Yeah,
and my urologist up there, once I got the cancer, he goes, let's take it out. He goes, that's the best thing to do. He goes, he doesn't believe in radiation. And it blows me away because this is a young guy. And so are they not teaching this stuff at universities or something? Because I was just, you always depend on your doctor. Now I'm going, cool, let's get this thing taken care of. And actually this month I was supposed to have it taken out, but luckily from a friend learned about you and whatnot. But
yeah.
it's just, don't they teach these young guys up there? Because he did not believe in it. He goes, it will not work. It was, you're wasting your time, is what he told me.
Wow.
So yeah.
Wow.
Wasting your time.
Sad.
Yeah.
What's that?
Wasting your time.
Yeah, that's exactly what he said. He goes, let's just get this done. And of course, I'm gonna believe what he says. So I was ready to go. Let's get this thing over with. And I'm just so happy a friend of a friend told us about you, and here we are. But it blows me away how this industry's like that.
Well, it's funny. I equate this whole thing to cars. I'm a car nut. And you can go to the Mercedes dealer and you see that convertible on the floor. It's $112,000. Say, wow, this is pretty nice. But before I buy it, you know what? I want to go down to the Porsche dealer down the block. And the salesman in the Mercedes showroom say, you don't want a Porsche. Those cars.
That's right.
This is no good, and that's no good. And traded values would be terrible. Just sign over here, you can take Mercedes. That's the same thing here with the, with
Yeah.
medical
Blows me away.
prostate. It all depends on who you speak to.
Yeah.
You know, there's that saying, you know, if all you have is a hammer, everything looks like a nail.
Is that maybe because prostate cancer is so complex? That you see variations with true believers, you know,
Yeah,
even
because-
among the medicals.
Yeah, you're right, because, you know, prostate cancer, you know, could be and should be cured, you know, and so you could do that with many different ways, you know, and I think, so, yeah, sure. You know, and you could be a believer in that way, but I think, you know, the urologists, that's what they're trained to do, and that's what they're gonna recommend. And there are 100 of those to one of me for Dr. Sutton, so, you know, they're out
There's
there.
only one Dr. D.
Right.
You're pretty well respected, because I've done a lot of talking,
Thank you.
and anybody who's ever been here, I've never met anyone who came who said anything that.
We try hard.
Final
Yes,
question.
Yeah.
Do you treat metastatic disease as well once it hits the bones?
Definitely, definitely, and someone mentioned Dr. Myers, Snuffy Myers.
Yep.
You did?
Yeah.
Yeah, he was a former chairman of the National Cancer Institute. He and I came up with that idea a long time ago, and we called it treatment of oligometastatic disease spread. And the thinking being that every canceritis, wherever it may be, fuels more cancer cells. So it's important to put them out, put the fire out, not only where it started, but everywhere else where the fire may have gone. There are a lot of interesting agents too that we use here. For example, for bone disease, it's actually an interesting thing since there's an enzyme, Rankel enzyme, which cancers use in the bone to propagate and to grow in that bone and to go to other bones. So we use a drug called denosumab, which shuts down that enzymatic pathway. In patients who have bone disease, we know they have bone mets, bone metastases, then we use the big brother, which is called Xgeva. And that's given monthly for a while, then we go to quarterly after a while. Its little brother is called Prolia. And we use that a lot too in patients having high risk disease where there is a risk for developing malignancy in the bone because it is prostate cancer and it may be high grade and we're concerned about that. So, but yeah, we have lots of treatment regimens for all different types, lymph node disease, bone disease, you know, even we've treated a lot of patients having both liver and lung disease too. Patients have a really good run with it. Okay, well, my clinic starts, so I just want to conclude first with Prostate Cafe.